Welcome! We're back, and while lots has changed over the past couple months, there is a lot that has not. Some things that have changed, it's a new year and vaccines are rolling out. Things that haven't changed, we are still living in a pandemic, we are still responding to it the same way we did 11 months ago, and we are still not entirely addressing inequalities. With all the questions we received about these topics, we are excited to host Dr. Stefan Beral on this episode. Dr. Beral is a physician epidemiologist who is also an associate professor at Johns Hopkins Bloomberg School of Public Health. Dr. Beral completed his undergrad, MSc, and med school in Ontario, followed by his MBA and MPH from Johns Hopkins. He is an expert in infectious diseases and their epidemiology and control, as well as health policy and management. So without further ado, here's Dr. Beral. Okay, perfect. So welcome, Dr. Stefan Beral. I'm very excited to have you on. We've actually, a month ago or so, we asked a lot of our listeners what their sort of big questions were about COVID, and most of them seemed to target your wheelhouse, which is why I was very excited to have you on in terms of inequalities in COVID, differences even in how the States versus Canada was handling it, because I know a lot of people tend to look at other places as the grass is always greener, but you never know, and possible steps forward. And so I think a good starting place is actually one of your tweets that I really liked was, I don't know who needs to hear this, but shitty social systems drive COVID-19 risks far more than individual choices. And if we could sort of start on that and broaden out.
Yeah. I mean, I think one thing to sort of think about in public health in general is that like this idea of blaming individuals for like suboptimal outcomes is not new. Like we do this as a society. We blame poor people for like the choices they made. We blame people who use substances for the choices that they made. We blame people with HIV, STIs. It's all, I mean, we blame people with mental health issues somehow for the choices that they made.
Yeah.
And so I think that like this idea, I mean, you literally could name almost anything, whether it be hypertension, obesity, mental health, substance use, infectious diseases. Like it's something that like throughout my career has been a common phenomenon of like trying to like develop an evidence base to argue back against this idea of just like that it's all at the individual level. So to that end, like we've developed conceptual frameworks, we've generated data, we have a whole field of evidence around stigma, that I've been working on for like 15 years. So I think as, COVID has amplified everything. It's just amplified everything in every way. But it was just so natural again that like people just wanted to blame this on individuals, because when we do that, it's just easier. It's easier on us. Like we've done nothing wrong. They've done something wrong. You get to other people all at the same time as you get to put the attention away from changing anything about like the system, which might affect the way we live or our own comforts, and focus more on the fact that like people got COVID because they made bad choices. Yeah. So I think what was striking for me was just like how similar it is with everything else that we've seen. And also like how the data don't support that at all. And it was obvious early. Yeah. I mean, and it wasn't just obvious early, it was conceptually obvious early that a respiratory pathogen would not affect all of us equally. But I think the data just spoke to it so clearly. Yet I think like our own desire, and I say like us as in society, because we just all have to own this, it's so much easier if we can just like push the blame away from us and the systems that reinforce inequities towards like choices. So I think, I think that's the basis of it. It's been part of it from the beginning, like the whole underlying idea of like, shut it down, stay home, save lives, like all of it has been, the sort of underlying idea has always been like, that the agency and the ability to prevent infection is all within the individual. And that's just fundamentally untrue.
Yeah. Yeah. Especially there's so many thoughts that I have coming from that. But one example, when you're talking about how it's just disproportionately affecting some populations, I think it was here in Ottawa where at the beginning when there was the full lockdown, you couldn't even go to a store, like other than grocery stores, but for example, all bathrooms were shut down to the public use. And then they were handing out fines to homeless people who had to go to the bathroom outside because they had nowhere to go in. And it's like, you're setting up things that almost guarantee their like criminalization. And it just,
No, I think it's amazing. So I provide care and shelters in Actually, our Royal Society of Canada report just came out today of shelters, homelessness and COVID, which is great. And so we're really excited that it came out. It was led by Jeff Turnbull, who's runs the inner city health program in Ottawa, and many of us participated. But it was amazing back then because, like, from a shelter perspective, we want folks ideally when it's warm out and it's safe to like leave the shelter during the day.
Mhm.
It, like, never mind like COVID prevention, just like it's just easier. Like, you can clean, there's not as many people in their rooms, etc. And so, like, yeah, we had people like, I mean, the most typical, like the most extreme example was like a guy, like, I don't know if you know this, but folks get $534 a month basically from the government,
Okay.
like that's the minimum. And they were giving out $800 fines. So we had a guy who came in with an $800 fine for being on a bench. This is like in late March.
Yeah.
And it was like
Oh,
$800, if he was actually to pay it, would be all of his money for 1 month and
yeah.
half of the next month. So it's like, obviously he can't, but it's exactly as you're saying. Like, we actually want them to go out. We
Yeah.
want, and so there's like just this like grave mismatch between like, like what we're asking folks to do. And then never mind the fact that like somebody sitting on a bench, like, I don't know if you know, in Toronto, like people gave so much attention to Trinity
Yeah.
Bellwoods. Like, it was like this park. I'm like, what, people should be out in a park. Why
Yeah.
are we so annoyed about people being out in a park? And it's like, there was no outbreak related to people being out in a park. There's never going to be one because it's just not the way it works. And beaches and all these things, like, but it's I think it's just that idea. And I think Julia, Marcus, and others talk about this, like anything where like it's perceived people are having a nice time in the
Yeah.
context of a pandemic means that they're not taking it seriously and they're part of the problem because they're not part of the solution. And I think it's just not good public health at
No.
its core.
Yeah. And it turns into almost such an extremist viewpoint. It's like if you even slightly agree with being able to go outside, suddenly you're agreeing to everyone dying. And it's like,
No, totally. That's right.
no. And it's almost this like the worst of all these things are coming together in terms of how you mentioned mental health even, and just being able to go outside. You're made to seem as if you do anything but sit on your couch, you're being the worst human ever. But then tie that into like, it's winter now, days are getting shorter, it's dark, you're home alone, you can't see anybody, you can't even go for a walk outside without like all the stigmatization. And we know that stigma leads to you further isolating, and then your mental health getting even worse. And then we're surprised that suicide rates are going up, or that substance abuse is going up. And it's like, oh, so much frustration.
Yeah. I mean, I think that, and the element, like, I'll just say this, like, there's been so much of a discussion is like, is suicide going up or not? And like, I find that an amazing thing because it's like, suicide to me is like, first of all, it's just the most extreme and tragic outcome of almost anything, but it's also like a very much like a lagging indicator. And so indeed, like, whether it's going up right now or not, like, people are stressed out,
Yeah.
and there's a lot of like steps in a pathway of like somebody gets stressed out and then they get depressed and then they have thoughts, even the thought, this like suicide ideation, and then they move towards planning, then they may even try. And so there's all these sort of like opportunities along the way. And so I think this like focus on like, has suicide gone up or not is purposefully, I don't know if it's purposely, it feels that way sometimes, of like taking the point across that people are stressed out and we should be trying to think about, like, from a public health perspective, like, where are the easy wins? Like, I remember like Halloween. Halloween was this
Yeah.
and it's like, they're outside. Most of them are wearing masks anyways. I mean, like, they're just like, it's a nice time, and there's never going to be anything related to like Halloween parties or just people being outside. So it's like an easy win for like, hey, have fun, go out, like, be safe, but have fun, have it be outdoors, don't have big indoor parties or whatnot. But it's not what we did. We literally shut down Halloween and outdoor activities. So I think we've like missed our opportunities to let people have a nice time, which is so critical because that gives them the energy then to be like, okay, I'm not going to have a big party,
Mhm.
or I'm not going to do these things. Because indeed, it's like, you know, you just end up driving people from wanting to be honest with you. And that again
Yeah.
that's also not new. Like, that's the same thing. Like, if somebody comes to me and said that like I had condomless sex, it's like, well, let's talk about that. Do you
Mhm.
know what I mean? As compared to like some shame based, like, why'd you do that?
Yeah.
We said you would wear a condom
Yeah.
every time. It's like, okay, fine. Like it's not ideal. It is what it is. But let's talk about like why that happened, how it happened, and thinking about sort of safe ways forward.
And I think that greatly ties into even the messaging that's been put out where it's very all or nothing, but then we're not
Totally.
thinking about people who they don't get paid to stay at home if they have COVID, or they have kids at home, and when the schools were shut down and then they couldn't go to work because they had to stay home with their kids, and then they're not getting paid, and how do they support their families? And I think something that's been missing is just saying, in the situations where you can't change what you're doing, how can you best approach it? Rather than saying, oh, you're doing that, no matter the reason, that's bad.
Yeah. No, I think that's right. I mean, the whole stay at home, save lives. I mean, it's so interesting because I'm part of like lots of like MD groups on like Facebook and others. And like, it was a lot of like stay home. I go to work so you can stay home messaging.
Yeah.
And I remember feeling this is like early March. I'm like, is that like really the case? Because like you're staying, but like you're ordering food in and you're ordering
Yeah.
Amazon, and like I'm like, there's a lot of people that need to go out. Like your internet's on, your
Mhm.
heat is on, your power's on, your groceries are moving. So I think there's like, that there's been this element of I don't know. I mean, I think there's just a need to sort of have a broader framing, because I remember talking to some folks who were like annoyed about their Amazon packages being late, but yet telling people to stay home. And I'm like, you have to understand, just say those two sentences together
Yeah.
right after each other. You're annoyed that your Amazon is taking longer than it should, and you want people to stay home. And it's like, I think that sort of, I don't know if it's cognitive dissonance or if it's whatever, but I think people have defined like it's been hard for me to understand why some services are essential and not others. And it only sort of feels like we've decided like what's essential based on like what's made to keep certain folks comfortable and
Mhm.
not others. Like if I'm going to stay home, like what are all the things I need?
Yeah.
And you sort of list them, even though like Amazon has had some of the worst outbreaks of all of them. It's a distribution center, and we've not heard like a peep. I think there's been like three Amazon stories in the news, and if I had to count the number of like parks, again, Trinity Bellwoods, it was like, I don't know, like 500 of them.
Yeah.
But yet we should be talking about Amazon every day. But nobody wants to talk about Amazon, because if we really shut down Amazon, things are going to change pretty dramatically for folks very quickly.
Yeah.
And so there's like almost this element of like tackling these very superficial, very visible things, like masks. Fine, I have no problem with masks. I'm happy to talk more about it. I have no problem with masks, but it's like it's so visible. Do you mean such a visible thing as compared to like really trying to address like why folks working at Amazon are at such high risk?
Yeah.
And so that to me also feels like a little bit like lazy public health, and it gets me in trouble because I trained in public health, but it doesn't feel like it's a very active strategy. It feels very like set a mandate, set it and forget it. And you're probably too young to remember this Ron Popeye, like the food dehydrator or whatnot, but he was like, or rotisserie chicken. It was like, set it and forget it. But it was like this idea of like, set a mandate and just forget about it. And the reality is like public health doesn't work like that.
Yeah.
We can have some mandates, we can do that, but we also have to think about all the active intervention strategies that we need to help people do what we would like them to do.
Mhm.
And if we forget that and just say like, hey, we've set this mandate and now you have to do it, we just aren't addressing the needs of the majority of folks. And by the way, the majority of folks who are at risk for COVID.
Yeah.
So
I have a couple questions on this, from pros and cons of how different places have handled it, and maybe what an okay middle ground would be. I know a big common comparator first off would be New Zealand. But they're an island. They can fully close off everything. They do a hard and strong like lockdown for a couple weeks, and then they kind of are able to go totally back to normal. And I think even recently they had like 3 community outbreaks. So they fully shut down hard and fast, and they have pretty good buy-in because they're able to go back to normal. Weird, not an island. I don't know how, like, do you think that Canada would realistically be able to do a hard and fast shutdown the way that they are able to in order to achieve this sort of outcome? Or how do we compare in that sense?
yeah, I mean, I think I will say this, that I worry gravely, just as an overarching sort of like public health principle.
Yeah,
I worry gravely about like the use of like synthesizing entire strategies of countries
yeah,
down to like sentences, like
totally.
let's do the New Zealand
Yeah.
model, because all of it, like implementation, for anybody who's actually led a program for anything, I actually don't care if it's like you literally had a lemonade stand, like you know that it's all about the details of like how often did you order lemonade, like how often, you know what I mean, what did you charge for the lemonade, like how often did you replace your lemonade, if you know, I mean, it's like a million different things that you have to think about in very specific, in the specifics of implementation. And we have an entire field, like I direct a doctorate program in implementation science where we only focus on this stuff. So it feels a little bit kind of close to home in terms of this idea of like, we used to do with this a lot in terms of like condoms, just like, it's like, well, okay, but like who distributes them, how do they distribute them, what education do they provide, like, so all these sort of implementation details are important. So how does that relate to, New Zealand and Canada? So like at it, I think that when this is all said and done, and I don't mean like now, I mean like a year from now, when we can have meaningful conversations and look at like what did they do and what was the context in which they did it? Because I think when we understand indeed like the context, then we can understand like what of those elements can we do in our own setting and which ones can't we? So, like some things that strike me as fundamentally different. One, it is an island. So, what does that mean in terms of how goods get there? Like just thinking out loud. Like I think transport, by the way, is such a fundamental part of our epidemic here.
Mhm.
And not because I blame them, like we're thankful for them, because basically everything around you, none of that was made in Canada. So just we all be thankful that transport exists. I always say, like, I think we do like Honey Crisp apples 2 weeks a year and everything else we import. Do you know what I mean? And
Yeah.
so like so but for them, like goods arrive via ship. And if outbreaks happen on the ship, like they fizzle by the time they arrive, or they can at least manage it. For us, people come from Florida to Ontario within 2 days carrying oranges and potentially like variant COVID.
Yeah. Yeah.
Like, and they don't get tested because there's like 10,000 trucks entering Ontario every day. So sure, if you set up a testing program, just like again in the weeds of like, what would that mean? Is it like, do they stay there for the 30 minutes or 45 minutes while you're waiting their test results? Who's going to staff that? How are you going to do it? Like, if you're going to say you're going to do something, get very real about what it means to actually do that thing. And so I think there's like, that's a fundamental context difference in terms of like, we don't have closed borders, because even though we close it to us, like non-essential, which is fine, we have so much movement across these borders both ways constantly every day, just as we speak, like truck, truck,
Yeah.
truck,
Yeah.
truck. And normally those trucks have 1 to 2 people on them. So I think there's that thing. Secondly, I would just say that like, so speaking from a personal basis, right, like, so my grandmother was a refugee to Australia from Poland, like the late 60s. And and so I looked at what happened like in Melbourne, because I think again it's all about what in the weeds. Like they shut down these, famously, right, the COVID Melbourne prisons, etc. These towers that were primarily, immigrant and refugees and racialized communities, and they sent 500 police into those areas, right? And you know, and they locked them down, whether or not you had COVID or not, like you were locked down. And then 4 days later, they shut down all of Melbourne. But initially, they did that. And I always kind of reflect, what would it be like if we did that in Ottawa or Toronto? Like, what if we sent 500 police officers to like Scarborough or, kind of parts of, Etobicoke, et cetera, like the parts that have been particularly affected, Peel, Peel, et cetera. And I just feel like we would never heal from it.
No.
Like we as a society would never heal. I don't know the areas well enough in Ottawa, but I just know that, we know there are gradients that are related to elements around structural racism and socioeconomic inequities, et cetera, that like, if we then punish people by sending police in,
Yeah.
I just think, especially don't forget, like in the context of last summer with like George Floyd protests and other things going on, that like that we would send police into more racialized areas and lock them down, felt like it would harm our societies in a way that it would just take us decades to heal from. And I didn't want it. So my feeling about New Zealand was like, I'm happy for them. Like,
Mm.
fine. Yeah, I actually don't, I think it's interesting, by the way, that like when you look at like local transmission in New Zealand, there's like the odd story where you see that 90% of the cases are among Maori and pacifist communities, like racialized communities in New Zealand, as compared to, a lot of their are obviously travel related, but that it seems like they also have those dynamics. We just don't hear about it. So there's also an element of like, who is this speaker? Like, have you ever heard somebody from New Zealand that is like a member of a racialized community of the Maori, like really saying like, we've loved this from the beginning? Because a few stories that I've been able to find feel like they have a very different perspective, very similar to what we're talking about. So I think there's also like, I think in the long term, I just don't think that New Zealand is going to be like the treasured model
Yeah.
of like how to respond to public health. And but that's not, I'm not talking about like we're going to feel that. I just feel like 3 or 4 years from now, when we can have rational conversations, people can say, wow, that was like heavy use of military, heavy use of police, lockdown, like these three folks, as you just talked about in Auckland, that were diagnosed, whisked off to a police run quarantine facility. And I just worry about that. I would worry if we did that here, because if you look at the COVID wards, they are reflective of the underlying socioeconomic inequities, and thus and racialized and there's racial inequities, and so we would be locking up primarily like lower income socioeconomically marginalized folks in these like COVID prisons.
Yeah.
And it doesn't feel like it would work in our setting. So
There was a lot of pushback. I think they tried to do something similar here not long ago, where if you return from travel and were waiting for your test, you would have to go to a hotel, but you had to pay for the 2 week stay. And then if you got another positive test, then they would take you to these like government run facilities. And I think they started talking about it, but they got so much pushback that I don't
Oh, I
think.
think it's happening. Oh, it's happening.
Okay,
So
I
the
wasn't.
details, yeah, yeah.
Okay.
So the detail, but so I'll just say a few things. One, this is for non-essential traffic,
Okay.
right? These are like,
Yeah.
so this is like part of our like, let's focus on people who flew to Florida,
Mhm.
not the people who drove with goods from Florida.
Yeah.
Do you know what I'm saying? Like,
Yeah.
we're
Yeah.
not focusing on the folks who like, we're just talking about the people who first, because it only applied and still only applies to air traffic and does not apply to land traffic. Now, land traffic, non-essential land traffic, you need a negative test. Essential land traffic, you don't need any test,
Okay.
because they don't want to mess with the systems of like how
Yeah.
goods move across our province.
Yeah.
So
Yeah.
this is what I mean, like of an intervention for show, right? So they are. So right now, the way it works is if you fly in, you have to stay for 3 days in a government-run hotel. Um, you have to pay for that. And I think if you test positive, so then you test at day 3 with the assumption that your last exposure would have been basically when you got on the airplane. So it would have been like, it should be positive by day 3. If it's positive, then you have to spend the full 14 days. If it's in that facility, if it's negative, you go home and do the next 11 days, assuming you have space to do it at home. You do it at home. But again, it's like, it's just like such for show, because it's so like our element, we have lots of local transmission. We're not addressing any of that. I heard Doug Ford today announce that like he would never think of doing paid leave, because why would the taxpayers have to double dip and pay people twice or something? But yet he's so ready to do these things. So I think it's just like, again, it's this idea of like moving towards very visible things. Like,
Yeah.
let's protect our borders, very nationalist. You
Yeah.
know what I mean? And again, isn't really getting at the heart of like what's actually happening, which is like essential traffic, what we call essential, moving goods across, being at incredible risk for them and their families. And we're not helping them at all.
Yeah. Yeah. Mentioning on the showcasing and that it seems that, I mean, we're running on almost a year now. We're at about 11 months of this. And it seems as though this is me not being someone who's making any policies from the outside. It seems like we're using the exact same tactics over and over again of there's something bad that happens, shame, blame, lockdown, and that's it. We just keep doing the lockdown, keep doing like there's no further attempt to try and deal with the inequalities that we've seen now for 11 months that have come to light and that people keep trying to bring to light. I think in Ottawa, there's now a separate clinic specifically for seniors from Aboriginal communities, which is great to get vaccinated. but it just like that's such a small thing and it feels like we're not really contributing. And I'm wondering like what if you could do it differently by this point, what would you have added?
Yeah, I mean, there's like a few fundamental elements. It's always because it's always easy to complain about interventions and not,
Mhm.
put forward ideas. And so I'll say it's like one thing to think about is like the sort of principles of intervention development. Like there's been a challenge in the way we've developed public health interventions, which has been mostly like people who look like me, like higher income white men, I mean, sitting on these groups and saying like what's best for everybody. And by the
Mhm.
way, that's not how it should work.
Yeah.
So even as I say these things, I'll just say it as in like this is not how intervention should be developed. Like public health should not be developing interventions for communities. I know that may sound strange, but you should be developing them with communities.
Yeah.
And it's really important. It's a fundamental principle. And I would say it's like there's like three fundamental principles of public health is, there's basically equity, which means that we do more for people who need more. This idea of social justice, which is that we balance the benefit and burden of any intervention, and participation, which means that we really work with the communities to develop interventions that are going to affect those communities. So the fundamental problem right now is that like we're not really doing any of that. And this is I'm not making these principles up. This is like I trained in public health in Canada. I wrote the Royal College exams in public health in Canada. Like those were the right answers.
Yeah.
So the idea being that like it shouldn't be people like me just like sitting here being like, oh, I know what's best for you.
Yeah.
We should be engaging people, talking to them, hearing what their challenges are. I can speak to some specific examples where we had that has shaped my perspectives as to like why this is such like a misguided response.
Mhm.
And goes far to say it's like the worst public health response in history. It's just like it's unimaginable, like you said, 11 months later that we're still doing this. But nonetheless, I think there's a couple key things. Like one of them is just about space. So, back in March, when the pandemic hit, like we set up an isolation site for homeless folks, as did many places across Canada, including in Ottawa. And we were taking calls. Like I hadn't been on call in a very long time. But we were on call basically running that site, myself and Tomislav Svoboda, who's kind of a legend in physicians serving homeless communities in Ontario, but in Toronto specifically. But he like lived there. He moved there and lived there for like the first 11 days at our COVID isolation site. And what I'll say is like, so I was taking the calls and admitting people, and what we were hearing from the emerge discharge planner. So back then it was sort of before the COVID assessment centers were up and running, and it was really all being done in the context of emergency rooms. And a lot of the calls we were getting were from people like, for us to admit people into our site, they had to be enrolled into the city's basically homeless program. So they had to have stayed in shelters before. And if they hadn't, we couldn't admit them. And there's a number of reasons as to why that is, but just that's the way it was. And these were city rules because officially it was a city-run facility, and we were just providing like the medical care and the public health care. Most of the calls we got from Emerge were like, "Hey, this person doesn't have room at home to isolate. Can you take them?" And the answer was no, we can't take them. And they're like, "Well, what do you suggest?" It's like, "Well, I suggest that they isolate." And they say, and it's like you're almost like, because it's like sometimes 3 a.m. Do you know what I mean? You're almost like you're almost like it's such a ridiculous thing to tell people like isolate in your home, and then they're saying that like you can hear them saying I have no space to isolate, and you're like yeah, but do your best. Do you know what I mean? And it's like so we sent all of those people home. That was like most of our calls. I mean, we admitted a lot of people as well, but most of our calls were people who didn't have the space to isolate, and we just sent them back into their homes. And by the way, we've been doing that effectively for 11 months. There's now a couple of these isolation sites. They didn't start till 5 months later, even though we knew we needed them, like day one.
Yeah.
So that one is just like we didn't give people the space that they needed to isolate. The second thing has been just fundamental is, I mean, I know now paid leave, I think has gotten more steam, but it's also just been the case that like everybody just kept thinking, oh, it's like CERB, people have CERB, but it's like CERB was for people who lost their jobs. Most of these folks did not lose their jobs. They worked at bakeries and they worked at whatever like rich people wanted them, to keep up. So bakeries, like I said, Amazon, distribution centers in general, Walmart, like whatever it is, Costco, Uber Eats, Amazon, you can name like dozens of things that we decided people, we as in government, us decided were essential to us. And we didn't give those people the option to stay home. A lot of those folks are agency hires and contract hires. So like if they phone their employer and say like, I'm not coming in, take me off for the next 2 weeks, they're not getting a dime, like not a nickel. And the benefit from the government was 450 a week after taxes for a maximum of 2 weeks. And by the way, you didn't get it until like a week later. So there was like, you were asking people to take on decisions that were very difficult for them to do because it's not just often them, it's like them and their families. And again, from a personal perspective, I've been managing outbreaks now in shelters for the last 11 months, but especially in the last 3 months where we've just had a ton of outbreaks. And they're always started by the same story, like an employee who didn't have benefits. It was like an agency hire because up to half the employees working in these centers now are agency hires because the system is so stretched with these additional hotels we're running and these other sites that like the actual city employees who have all the benefits are like spread across the city. And we pulled in a lot of agency hires and they have no benefits. And it's like they wake up with the sniffles one day and they're like, well, it can't be COVID because COVID, I should be like on death's door with COVID. And then they come into a facility. And by the way, people have died from those outbreaks, because they, and I don't blame that person because I hope to never be in their shoes where they feel that pressure to go to work to get a paycheck. So, I mean, that has just been fundamental of like just the idea of like giving people like this, the space and the resources that they need. And then the third thing has just been about like even how we've done testing. Like testing has been best designed for rich people. Not only the locations where it's been offered, but the hours in which it's been offered and how it's been offered and how it's been messaged. So like we just haven't used that sort of community-based delivery strategy in most places. Like there are definitely shining examples, and I think Ottawa's done a lot of this. So this is like broad strokes, but
Yeah.
but it definitely hasn't been the norm. The
Yeah.
norm has been at large hospitals, tertiary care centers, between 9 to 5 or 8 to 8 or something, and like banking hour type things. And like for shift workers and others, who don't have private transport, it just isn't well set up for them. And so I think, it's those three things I think are fundamental and I think would have made a big change, but they require active interventions. They necessitate us to like do something rather than just like a mandate and telling people not to do something. And I think that switch towards like active intervention strategies is, I would have thought actually would have happened by now. It felt like we're going into wave two. I'm like, are we still talking about strip clubs, or are we actually going to like do something? Yeah. Do you know what I mean? Like meaningful and empiric and equitable. And the answer was no, we are not going to do any of those things. And we got exactly what we deserve. And not us. I mean, I just, and the tragedy has been just people, just like what's happened as a result over like the last 4 or 5 months, because we did nothing for those folks.
Yeah, it seems almost like we just keep putting band-aids on, trying to make it look nice, and we're not actually addressing those. Circling back to your second point and the differences, and I'm curious on your opinion on this, because this is something that I've had a thought about. Like while dog walking, we met a couple and they have like a mom and pop just deli, and they had to shut down because in terms of the grants that the government was given, I think, if I'm not mistaken, it was if you've lost like at least 70% of your income, then they'd give you a certain amount of funding to help you get along if you're a small business. And they had only lost 50% of their income. So they had lost enough that they couldn't continue, but they didn't lose enough to get the grants. Then they were forced to shut down. And then it almost seems like these smaller areas these smaller shops are closing, and then everyone's sort of forced to go to a big Costco or a big superstore where there's lines out the door and lines in the store. And it almost seems like it doesn't make sense that you're almost forcing this funnel of people into one shop to close down the little ones to say that we're trying to reduce spreading, when wouldn't keeping more shops open sort of distribute everyone a little further apart? But I don't know if I'm missing something.
I think what you're describing is just like, it's just so not empiric. It's so like, just like, I don't even know how to describe intervention development lately, but it doesn't feel like empiricism is a big part of the story. It just feels like some people sitting in a room being like, let's do this, or let's do that. It doesn't feel like it's responsive to the epidemiology. So fine, you can say that in like month 2 or month 3 even, but month 11,
Yeah.
do you know what I mean? That we don't have like good enough data to react to. So I think what you're describing, and I feel this a lot, is just like I am often asked to explain these interventions to people. And I feel like I should be able to explain almost any intervention. I feel like I don't know if I've done enough training. I've taught public health for a long time. I've done all, it's
Yeah.
just like I can't understand. I can't explain it. I can't understand it.
Yeah.
And I think and it's because it's like it's just doesn't feel very empiric. So indeed, like I don't know that there's any evidence to support that like big box retail is any safer at all, at
Yeah.
all. I don't know that there's been like that we can describe like a lot of outbreaks related to, like small mom and pop shops versus like, again, Amazon distribution centers, et cetera. And I think that those folks can absolutely do things safe. And I say this, by the way, I have no connection to like a small business. I have no connection to a restaurant. I have no financial connection to anything. And like, I'm basically, from a personal perspective, like I'm a big believer in like our safe social safety nets and et cetera. But I also understand that like capitalism exists,
Yeah.
and it's how a lot of people, gain their incomes and support their families and do all that. And so I think it's like to say that like the economy doesn't matter is first of all wrong, because employment, by the way, is an established social determinant of health, and people being employed has benefits not just from their immediate ones in terms of supporting their families, but just like general well-being and mental health, et cetera. But I think it's also that like I also just don't understand why we've made some of the decisions and closed some things and not others. And what's amazing though is that the economy seems stronger when we close small businesses, which is like blows my mind,
Yeah.
right? Because it's like there's just this element of like, I mean, like this was out in the New York Times for the U.S. that the U.S. economy is like $1 trillion bigger because richer companies have done so much better, and it's just easier to pay people unemployment for like the low income folks who have lost their jobs. So there seems like there's never been a greater disconnect between like Main Street and Wall Street. You often say, and with the um, let's say Bay Street, and but in
Yeah.
Canada, but just this idea of like that those folks actually are doing fine. People are saving more money, and they're not spending as much, and they're investing it in all kinds of ways. But that and stocks are doing great, but like the amount of like individual folks that are squeezed is incredible. And I think like that happening and also not fully understanding the public health benefits of those interventions makes it feel particularly problematic to me.
Yeah.
So, you know.
And I have a final question to sort of full circle, coming back to another one of your tweets that I want to end on, where you had mentioned that normally elimination is the ultimate goal in public health, but that isn't true for a lot of infectious diseases. And we seem to be treating COVID as we're only going to get back to normal once it's eliminated. And if you could just touch on that and the potential reasons that that's not the best way to sort of focus on this.
Yeah. I'll just say this. I think some people focus on like COVID zero as a slogan.
Mm-hmm.
No problem. I think that, there are folks that feel that like the move towards a COVID zero campaign, it's like if you help everybody, then poor people get helped as well, kind of thing. And it very much feels like trickle down. I remember I sort of felt this. It was like, because you've heard this before, where it's like, if you give tax cuts to the rich, poor people will benefit. Like it's like what we call trickle down economics or Reaganomics, And it just didn't play out that way. It was just like, it just wasn't like actually folks do best if you make it better for them, not if you make it better for rich people. And the same thing applies, I think, in public health. Like saying you're going to help like generally wealthier people will eventually trickle down to help lower income folks. I just don't think we have great evidence for that. But I will say, so like at its core, elimination, I think there's sort of like 4 criteria that I think of when you can think about eliminating a disease. 1, you can test and diagnose basically everybody. So you have a test that like diagnoses everybody. 2, there's no animal reservoir, right? 3, there is like a biological tool that can prevent that infection. And 4, you have an effective surveillance system that after you've put in your tool, after you've used your tool, like let's say a vaccine, you would be able to pick up any, like infections if they pop up. So we do that polio, is a great example. Like, we can prevent the infection, we can diagnose it perfectly well, but clinical criteria and obviously biological testing, and we have a great surveillance system in place. So for like COVID, actually, like our PCR test, I don't, we don't need to get into a whole PCR conversation, but obviously a lot of conversations about like utility of testing. And we have plenty of folks who test negative based on the timing of that test, who actually have COVID, and by the way, could potentially infect others. So like that criteria is problematic. Secondly, there's a bunch of animal reservoirs already. We know that for other coronaviruses, like there are animal reservoirs, ferrets, minks, and we can't keep like, you may have seen what the Danes did to the minks, and just culling huge amounts of animals. But like it's in bears, it's in like in all mustelids basically. So like weasels, etc. Like we saw examples of it being in cats, dogs, etc. Like it's in animals, and so that's just the reality. Like it's now in animals, and that's a key criteria. Third thing are vaccinations, which are amazing, right? Probably don't prevent infection as much as we'd like them to, but are amazing at preventing people from getting sick, which by the way is like what I really care about. And I think many of us in public health care about is like, it prevents people from like, I don't know that there's been a single person that has been vaccinated and 10 days out from the second that has died from COVID. I think, it's like, that's amazing, and is just, and we need to sort of scale it up, but it doesn't prevent infection. So like COVID is going to like hang around, even after we scale up vaccination. And the third thing is like, we don't have a surveillance system for COVID because it's so complicated, because there's so much asymptomatic infection that like, or pre-symptomatic, or people with really mild symptoms, that it just doesn't declare itself. So like, I don't know how, unless we're literally going to be like for the rest of our lives testing ourselves before we go out of the house in the morning and come back at night, or I don't know what even that looks like, but something along those lines.
Yeah.
So like those four criteria make it like traditional elimination strategies, because people thought of elimination before COVID. It's not like this was the first time we ever considered elimination. Like everybody would love elimination. I would love elimination. I'd love to never have heard of COVID and never hear again about COVID, and that nobody would ever get sick from COVID again. It's just like, what are the things that we're doing to get there? And I think, so for me, it wouldn't be like, I wouldn't focus on a COVID zero goal, because although there's a lot of conversations about like a third wave happening now, I actually tend to not think that. But I know that come next winter, that there will be COVID cases again. With vaccination, there will be COVID cases. They'll probably be less sick, ideally, if we've done better in terms of vaccination. But there will be people who get COVID again. So like, what are we going to do then? And I think if our goal is exclusively COVID zero, then I don't know, do we shut down again next September? In 2021, I mean, right? Like October 2021, or do we focus more on hospitalization and say, actually, okay, COVID is with us now, and now we're going to focus on something else? So I think that the thing is, like, I don't understand what the exit strategy is from a COVID zero goal. So if it's just like an aspirational slogan, it's fine. But like all of this is like, when do we get real about the actual services that we're going to provide? And again, I worry in next fall that we're going to have COVID cases again if we're testing for them. And we're just going to have to accept that some level of spread is going to be acceptable, not because I'm a bad human being, but just because I think it's just a realistic perspective.
Yeah, no, I agree. Okay, fantastic. Well, this answers so many questions that we had. So I really appreciate you coming on and talking about it. I think it'll really benefit everyone who's been just wanting to know more about the differences. And yeah, thank you so much. I really appreciate it.
Okay, take care.
Thank you. You as well. Bye.
Bye.
Thanks so much for listening. This was a special episode that hopefully addresses many of the questions and thoughts that have been lingering our minds. If you enjoyed this episode, please leave us your thoughts and comments, and follow or subscribe on all streaming platforms. To hear more from Dr. Beral, you can find him on Twitter at SDBARAL. Thanks, and have a great Monday.